Hi, my name is Sonia Liebendorfer, and I'm going to be talking to you today about Parkinson's disease. We're going to be going over the causes of the illness, as well as the medications that are available, some alternative therapies to treatment, and also go over the nursing considerations for care. Parkinson's disease is a neurodegenerative disorder that's caused by the loss of the dopaminergic neurons in the substantia nigra. That is located in the midbrain. Now, when you look at this photo down at the bottom, at the very top, you see a non-Parkinson's brain, and you see those little jagged areas. Those are actually areas where they're demonstrating a synapse between neurotransmitters. So when there's a dopamine deficiency, they're having trouble getting those impulses across to the neurons across that synapse. Now, when you look at the bottom in the Parkinson's brain, you see that those areas are filled up. And we're going to talk about how those areas get filled up and why there is such difficulty in getting nerve impulses to the brain across the synapses once these areas get filled in. Pathophysiology of Parkinson's disease. Well, Parkinson's has been around for a long time, so what exactly have we learned about the causes and what's being done about it? That's most of what we're going to be talking about for the rest of this presentation. Well, Parkinson's disease is associated with an abnormal protein accumulation as well as aggregation, which means not only do they collect, but they also stick together, which causes issues. For dopamine, that's why it has trouble getting across that synapse. It also causes mitochondrial abnormalities. It causes changes in being able to break down cells because of lysosomal degradation. You can't get rid of the debris anymore, so it starts to build up. And neuronal loss of the dopaminergic neurons that get across that synapse. Those three components all make up Parkinson's. And it starts in the substantia nigra, but we will find out that it also goes to other places in the brain in the form of Lewy bodies. As far as the pathophysiology for Parkinson's disease, the disease progression is usually over 10 to 15 years, producing severe motor problems to the point of near immobility at the time of death. And death is usually the result of either aspiration pneumonia or falls or complications from falls. Treatment is used to alleviate the symptoms, to give them a better quality of life. However, it does not slow down the disease progression. Concerning the pathophysiology of Parkinson's, the alpha-synuclein protein accumulation is what causes the disease and causes the lack of impaired autophagy with this disease. And the alpha-synuclein protein, the gene encoding it is autosomal dominant, so it is hereditary, but you can also see Parkinson's caused by things such as exposure to chemicals, which cause the gene encoding derivatives that cause Parkinson's-like symptoms in patients. Another diagnostic feature of Parkinson's is the Lewy body, and it is an inclusion that contains all these proteins that is really not diagnostic until post-mortem, when they can actually stain the brain cells and cause them to show up. This protein buildup is what causes all of the changes in Parkinson's patients, because as these protein bodies build up in the brain, they cause more and more problems with being able to perform bodily functions. You usually see Lewy body dementia follow after a year or so of motor symptoms. Sometimes it takes longer, sometimes shorter. The main characteristics that you will see with Lewy body dementia are a person will have a lot of hallucinations, especially after just waking up, not being able to realize what's real and what's not. Another thing that you will see is their emotions are very labile. They can go from very cooperative to very agitated to very combative in no time at all. And you have to really be monitoring their body language when you're talking to people that have Lewy body dementia because everything changes rapidly. Now we're going to look at some of the pharmacological treatments for Parkinson's disease. The first one is L-DOPA. The other name for it is L-dihydroxyphenylalanine. And it's initially the drug used to control the characteristic tremors, rigidity, bradykinesia, and gait problems. Dosing is highly individualized to deliver the least amount of drug that will resolve the patient's problems. And L-DOPA becomes less effective over time and begins to cause problematic fluctuations in motor function. The more you add, the more you have the additive effect of having mobility problems, which in essence, they're just compounded once you start giving too much of the drug. When you give L-DOPA by itself, it can be very debilitating because when you give it by itself, it takes an awful lot of the drug to get into the brain. So there's this wonderful combination drug that they have come out with called levodopa-carbidopa. And the way that it works is you can think of carbidopa as a vehicle that levodopa rides on to get across that blood-brain barrier into the brain, where it can be used as dopamine. And it's wonderful because it enables us to use less of the levodopa. And the less we can use, the better, because it's the longer that we can have the anticipated effect of improving quality of life for our Parkinson's patients. So carbidopa, as our vehicle, prevents the breakdown of that levodopa in the bloodstream. So more levodopa can cross into the blood-brain barrier, and this therefore reduces some of levodopa's side effects, which are nausea and vomiting most commonly. Now, the brand names of Rytary and Sinemet are the medications that are most known now as far as treatment for it. 25 milligrams of levodopa to 100 milligrams of carbidopa. Or you'll see the dose of 50 milligrams of levodopa to 200 milligrams of carbidopa as our vehicle to carry it in. You don't want to go over 1,600 milligrams daily of the drug. Now, PARKOPA is another medication that is the carbidopa-levodopa, which dissolves on the tongue. And you might see it used for the dysphagia patients that are getting to the point that they're choking whenever they try to swallow. They can use it to help with their symptoms, but until they reach a point of diminishing returns in which it's more of a risk even to give it that way, because they do get to a point that they can't swallow even their saliva at all. Pramipexole, brand name is Mirapex. Side effects for this drug are dizziness, drowsiness, nausea, and hallucinations. Dyskinesias can get worse if you use it with levodopa. Interactions include diltiazem, verapamil, cimetidine, ranitidine, and quinidine. Quinidine is the antimalarial drug that can also be used as an antiarrhythmic, so make sure you're verifying what your patients are on before you give them this drug. They also have a tendency they can have severe reactions such as hemolytic anemia, agranulocytosis, leukopenia, and sleep attacks. So you see those anemia and the granulocytosis and leukopenia, so you know immediately that periodically you're going to have to be checking lab work on this patient, do a CBC with differential to find out if there's any of this going on. And as far as sleep attacks, these people can go to sleep without warning. So we need to make sure they're not driving. Make sure family members are taking them somewhere or making sure that they have a ride somewhere because they don't need to be driving. They shouldn't be driving with Parkinson's disease anyway because it's too hard to tell between the brake and the gas. But in any event, if they are driving, they're at risk for these sleep attacks, which is falling asleep without warning. So they definitely don't need to be driving, and we need to put a stop to it if we see that they still are. And if the families aren't taking the keys away from them, then it's definitely a problem because they're putting everybody at risk on the road. Benztropine or cogentin is an anticholinergic that's used to treat the extrapyramidal symptoms. Remember, we talked about the more you give this drug, eventually you reach a point that you're just worsening the symptoms instead of actually helping with them. Well, what cogentin does is it takes away those extra symptoms that are caused by the medication, but it does not help the symptoms itself that's caused by the debilitation of the disease. It just takes away the worsening that's caused by getting to a point that you're taking a large amount of this medicine that it makes the symptoms worse. So side effects with this medicine are constipation, dry mouth, blurred vision, urinary retention, and confusion. And it is important to note that they interact with, here is clonidine again. So you also know from that that it is not only antimalarial, but it is an antiarrhythmic. So you're going to have to look closely at those meds again. It interacts with antihistamines, tricyclic antidepressants, MAOIs, and phenothiazines. A non-pharmacological treatment that's available for patients with Parkinson's is a deep brain stimulator. It's placed by a neurosurgeon in either the thalamus or subthalamus in the brain, and it uses electric currents to deliver a shock to the cells that are causing tremors to get them to stop and to alleviate the tremor. It's a last resort when medications aren't really working to help with the tremors anymore. A lot of people don't want to have neurosurgery, but if patients are having a problem enough with quality of life from not being able to do things because of tremors, I've seen people undergo this procedure and have success with it. But just keep in mind that over time, even with that brain stimulator in place, they're going to have trouble with tremors later on. When we think about non-traditional treatments for Parkinson's disease, they have found that marijuana actually helps with the treatment of Parkinson's. First of all, it helps with the tremors, which should come as no surprise, seeing as we're using it for children for seizures that can't be controlled by medications. It also helps with appetite because it eases the tremors and helps them be able to hold eating utensils better to be able to get the food actually in their body. They get so frustrated with trying to eat that they just lose their appetite before they even have a chance to eat anything most of the time. It helps with sleep difficulty because a lot of times they wake up, they have trouble with muscle spasms a lot, and it helps them to be able to relax and get some decent sleep. This helps with their anxiety levels and also helps with depression. Now, hemp is the form of marijuana that does not have any THC in it, and it has the same benefits as marijuana, just doesn't have the psychotropic effect of a high because it doesn't have the THC. They have found through research that marijuana, for whatever reason, has more of a neuroprotective effect on the brain of Parkinson's patients than conventional medications, and that also the benefits of marijuana last longer than traditional medications. And I can only imagine that this is because marijuana is a natural drug, and natural versus synthetic, of course, you're going to get better benefits from the natural solution. I just want to really caution you about using Zofran with patients that are on Parkinson's medications. I've been a nurse for 16 years, and in the time that I have been a nurse, I haven't seen a whole lot in the literature about interactions between Zofran and Parkinson's medicines, but I have seen flyers in ERs warning you about mixing Zofran and Parkinson's medicines. So their warnings are there. They just don't put them in the literature for whatever reason, other than pamphlets that happen to be on a wall in some ERs that I've worked in. But Zofran is really contraindicated with Parkinson's patients because of a medication interaction. Not really sure which one it's interacting with, but it will cause severe symptomatic bradycardia in these patients if you push Zofran. Don't even have to push it fast. It doesn't matter. It causes severe symptomatic bradycardia. Also causes torsades. I've seen that happen. So be very careful. We know that nausea is common with levodopa, but be very careful when you're giving Zofran to anyone that's on Parkinson's medication because they have some kind of interaction, and I don't know which medication causes it, but it's a scary thing when you experience it with your patient. Thankfully, nothing has happened as far as adverse events with my patients, but you really have to watch Zofran when giving it to a patient that's on Parkinson's meds. As far as nursing considerations for the Parkinson's patient and family, remember there is no cure. Treatment does not slow down the progression of the disease. Treatment is merely to preserve the quality of daily living as long as we can for that patient by replacing the dopamine that is lost. Remember, periodic lab work is going to be needed to check for complications as far as compromise of organs with either the liver or the kidneys for drug clearance, and also being looking for complications with medications as far as those that cause anemia, leukopenia. We're going to be checking either CBCs and organ function with chemistries and just make sure that everything looks okay. If a patient worsens suddenly, then make sure that the family knows to notify the provider immediately and encourage the family to work together and to provide care due to caregiver burnout. Usually one person, the one that's been with them for the most amount of time, usually a spouse, doesn't want to take a break, doesn't want to get away, but everybody needs to be involved because it's going to be a lot for that person to deal with, and their health may be affected if they aren't given the proper support. And as the patient declines, make sure that you are aware not only of comfort measures for the family, but comfort measures for the patient. Make sure that you're keeping them comfortable because there would be nothing worse than choking on your own saliva and not being able to clear your own airway. So make sure that you keep that airway clear and make sure that you keep that patient comfortable so they can rest easy going into the next life and not suffer.